Okay, so my topic is improving outcome in biliary atresia patients, those who have transitioned to adult care with a native liver. So it's a very specific group which I have been asked to address. So as we all know that biliary atresia accounts for about 40% of all neonatal cholestasis. And it's a basic problem is that the bile ducts, both extra and intrahepatic, are being destroyed. There is chronic inflammation, there is liver fibrosis and cirrhosis. And the basic problem can be summarized as an inadequate bile flow in the setting of a fibrotic or a cirrhotic liver. There are two main treatments in biliary atresia. One is Kasai portoenterostomy, which is basically we join the bowel to the porta, and the earlier it is done, the better are the results. But overall, about 60% you can say in the best of the centers, it will be able to successfully establish the bile flow, by which we mean that jaundice will clear. The second treatment is liver transplantation, which could be a primary when there is a late diagnosis without a Kasai portoenterostomy, or after a Kasai portoenterostomy, early in the first decade in those who fail, these 40% who have a failed Kasai, or later on in childhood or as adults in those who have a successful. There is no, without a Kasai portoenterostomy or a liver transplantation, the patient is not going to survive beyond 2 or 3 years of age. So the transition of care of biliary atresia patients, when we as pediatricians transition them to the adult side, is mostly at 16 to 18 years of age. And this is the age which we call as young adults, that is anywhere from 16 to 25, which is the vulnerable group in all terms, whether it is compliance, whether it is autonomy, whether it is making decisions. It's a very handle with care kind of a group of patients. And so at the first thing which we can do is that we have an early diagnosis, early Kasai portoenterostomy, improve care thereafter, so that we can increase the number of patients who are actually reaching 16 years of age, so that we can hand them over to our adult colleagues. So the adult hepatologist needs to know about the complications of BA and the long-term consequences of liver transplantation in children, because we heard in the yesterday Anupam's and otherwise also saying that 80-85% children post transplant for various reasons are reaching adulthood. But this is not the group which I have been asked to address. I have been asked to address those who are going to the native liver. So let's look at across the studies, the long-term outcome in biliary atresia. I have taken 20 years because 16 to 25. So if you look at it, overall, in the best of the European centers in Japan and other places, roughly 80 to 89% patients of biliary atresia are surviving. Post-liver transplant, it is about 80 to 89%, and native liver survival is about 26 to 49%. So if you look at these two important series, one is from Birmingham Children, you can see that 454 biliary atresia, mind you, 95% of these children are undergoing a Kasai portoenterostomy. And the 20-year native liver survival is about 30%. The French series, again, 20-year native liver survival, 26%. The studies from Japan have shown roughly about 49 to 50% native liver survival at 20 years. So the truth is that the adult hepatologist, if we transition our children at about 18 or 20 years, will get BA, if he gets 100 BA patients we are transferring, only 1/3 would go with their native liver with the best possible Western results. 2/3 would be handled over by after they have undergone a liver transplant. This is the truth in the best of the centers, and this is my dream. As you can see here, this is the oldest Japanese survivor who's now 61 years of age. And she's absolutely well with no minimal evidence of jaundice. And obviously this patient was operated by Dr. Kasai. So you can see that this can happen. And what we are actually, what I am saying is the Western perspective. Because if I think of my center, in contrast to 95% patients getting Kasai portoenterostomy, not even 25% patients are getting Kasai portoenterostomy. So somebody who's not able to even get a Kasai portoenterostomy, you can imagine, is not going to get a liver transplant patient. So 3 out of 4 biliary atresia patients in this country are still dying without any specific treatment. So what happens actually in biliary atresia is that there is no cure, as I said. Kasai potentrostomy is actually palliation, and the ongoing fibrosis is just ongoing. So as the time proceeds, you can see that the native liver survival from 100% comes down to roughly about 30%, you can say. There is cirrhosis, there is esophageal varices, there is cholangitis, there is malignancies. And when we transition our BA patients to the adult colleagues, this is what we are gifting them. A patient with varying degree of fibrosis to cirrhosis with the native liver, transitioning over at about 18 years of age. So a young adult with biliary atresia with a native liver, what are the issues? Portal hypertension, cholangitis, pulmonary complications, poor bone health, nutrition, HCC, liver failure, need of transplant, concerns about childbearing and pregnancy, quality of life, and preventing secondary hepatic insult secondary to infection, alcohol, or hepatotoxic drugs. So portal hypertension is almost seen in vast majority. You can see roughly about 60 to 70% of patients with biliary atresia at about 15 plus years of age will have portal hypertension, and they will need to be managed just like the regular ones. After they have had a variceal hemorrhage, the survival, only a third of these patients are going to survive with the native liver. So variceal hemorrhage is a red herring, and a liver stiffness more than 24 has been shown that this is a predictor for portal hypertension in the specific setting of biliary atresia. Cholangitis is a very important factor in these patients. Roughly about 40% of patients will have cholangitis even as young adults. We know that cholangitis is most common in the post-transplant, post-Kasai potentrostomy, the initial 2 years, but later on also they can develop cholangitis. And this has been very clearly shown that this is a study which showed that of the 60 patients with biliary atresia more than 20 years of age, the ones who had cholangitis, they required the higher need of transplantation. So this, if it is occurring in a young adult cholangitis, you can take it as a red herring that yes, your patient is deteriorating and consider for transplant. Liver transplant should be considered in these patients if they are having recurrent cholangitis, multi-resistant bacterial organisms, life-threatening sepsis, or severe impaired quality of life due to recurrent hospitalizations. Pulmonary issues, we all know that hepatopulmonary syndrome and portopulmonary hypertension are two important complications. For some unknown reason, biliary atresia patients are at a much higher risk of developing hepatopulmonary syndrome as compared to other causes of CLD. And even in BA, it is much higher in the BASM or the biliary atresia splenic malformation syndrome. So you have to take a history, but then most of these patients are usually asymptomatic. And this develops much earlier at around 5 to 7 years of age in comparison to the portopulmonary hypertension, which usually happens much later at around 15 to 16 years of age. And this portopulmonary hypertension has a very bad prognosis. Even despite liver transplantation, 50% of the patients are not doing well, in contrast to hepatopulmonary syndrome, which has got a much better outcome post-liver transplant. So all young adults with biliary atresia should get routine cardiac echocardiograms. Don't depend on just the pulse ox saturation because it's not 100% sensitive or specific. It is a good marker if your patient is developing polycythemia or his hemoglobin is going up. That could be a indirect evidence that this child is hypoxic. But still, I would suggest that, and the recommendation is that you should get an yearly echocardiogram, and these patients are best diagnosed in an asymptomatic state. Hepatocellular carcinoma is an uncommon complication in biliary atresia. It's seen in about 1% of the patients. And if it develops, we have, obviously, all cirrhotics will need screening. And if it develops, then obviously liver transplant is the only viable treatment in this setting. Now, two important things are that once you have these patients and you are considering transplantation, there are two very elegant studies from King's College which have clearly shown, in this study they had 36 patients who were listed for liver transplant, and you can see the age was from 14 to 19 years of age. The indications were cholangitis, variceal bleed, and synthetic failure. Those patients who were listed by the adult hepatologist, in contrast to those patients who were listed by the pediatric team. The ones who were listed by the adult hepatologist waited longer before the transplant, required ICU support at the time of listing, and admission to the ICU at the time of listing was associated with a poorer patient and graft survival. So as you can see from the graphs, those patients who were listed by the adult hepatologist had a poorer patient and graft survival as compared to those which were listed by the pediatric transplant physicians. And this is basically because the pediatric hepatologist is more familiar with these conditions. They list them at a much early point, and therefore the timing of the liver transplantation needs to be fine-tuned so that these patients do not decompensate and they have a better long-term criteria. The 16 and 18-year transplant listing criteria also in the Western world, obviously, as adults and pediatric are different, and that could also be accounting for one of these problems. And this has been shown by the King's College again, that the indications, the classical cutoffs which we take, the MELD criteria and the UK ELD criteria, these are not specific for biliary atresia because these patients have more of portal hypertension and cholangitis. So they will have a preserved creatinine or a lower creatinine, they will have minimal high bilirubin, and still they will do badly. So you need to be aware, and perhaps we need to have specific biliary atresia liver disease related criteria for listing if we want to consider this. Apart from this, these patients may have cardiac problems, long-term portal hypertension, multiple aneurysms of splenic arteries, and transplant-related issues can be there, which need to be considered and which the adult hepatologists need to be aware that yes, these are the additional problems in patients who have undergone a Kasai portoenterostomy and are being considered for the liver transplant. Before transplant, it's always better to consider early, give time for educating the young adult, and obviously involve always a psychologist and an individualized approach in the care of these children. The health status, there are 3 studies which have shown that these people do pretty well, just like their adult counterparts. There may be some issues with women, and with the Japanese patients they had a poorer general health, but overall 60 to 100% of adult BA patients were employed and they were scoring pretty well. Pregnancy has been it has been reported in 20 to 30% of female patients in biliary atresia. Only thing is that pregnancy can lead to deterioration if it is happening, so you need to monitor them very carefully, and portal hypertension and variceal bleed can be fatal. Therefore, you need to undergo a screening endoscopy in the second trimester. And those patients who have got a MELD score of 6 with cirrhosis prior to becoming pregnant need extra care because their risk for both the baby and the mother is increased. Nutrition and immunization needs to be taken care of. Metabolic bone disease is very well known. It may cause fractures with minimal trauma, and significant bone mineral deficits have been shown even in patients who are non-jaundiced. So you need to be looking after that. You need to look after the psychological issues. You need to educate them about IV drugs, alcohol, and hepatotoxic drug intake. Make sure that they are following contraceptive advice and they are vaccinated, especially for the biliary atresia splenic malformation group. They need extended vaccinations like pneumococcus and meningococcus also. So to conclude, I would like to say that roughly about 30% in the Western world. In the Indian world, the situation is absolutely dismal, and I think it's one of the diseases where we have failed terribly, terribly, and terribly. So the Western world, 30% will reach adulthood with the native liver. So we should make all efforts for early diagnosis and Kasai portoenterostomy before 2 months of age. The adult hepatologist needs to know about the problems of biliary atresia after transition and its treatment. The phenotype of young adult with biliary atresia differs from the typical adult liver disease, which is related to alcohol or viral hepatitis. It's majority portal hypertension and cholangitis with variable degree of liver dysfunction. You need to keep this in mind. They are at a higher risk of hepatopulmonary and portopulmonary hypertension. Pregnancy is high risk. Psychological stressors need to be addressed. There is a mild compromise of quality of life, but otherwise they do well. And the currently used prognostic models for taking them for transplant do not perform optimally in this group. That needs to be kept at the back of the mind. So what to do? treatment by a multidisciplinary team, especially in the young adult age group. We need a very proper support for this fragile community or fragile age group. Serial monitoring with clinical examination, nutritional health, bone health, endoscopy for varices, ultrasounds for biliary abnormalities, portal hypertension, liver SOL, yearly echocardiograms and cardiology consults, pre-pregnancy counsel, screening for varices in the second trimester, timely listing for transplant of native liver survival, and counseling about the lifestyle measures and socio-emotional issues. Thank you very much.
Thank you very much.